Welcome to Using Data and Information Systems and Partnered Research, a cyber seminar series hosted by VIREC, the VA Information Resource Center. And thank you to CIDR for providing promotional and technical support. This series focuses on VA data use in both quality improvement and operations research partnerships. This includes query projects and partnered evaluation initiatives. These seminars are held on the third Tuesday of every month at 12 p.m. Eastern. You can find more information about this series and other VIREC cyber seminars on VIREC's website, and you can catch up on previous sessions on HSR&D's VIREC Cyber Seminar Archive. This is a quick reminder for those of you just joining us, the slides are available for download. This is a screenshot of the sample email you should have received today before the session. In it, you will find the link to download the slides. Today's presentation is titled, Using National Power BI Dashboards to Improve Patient Safety and Quality of Care. Presented by Dr. Mary Whooley, Tonya Kaltenbach, Gabriela Schmajuk, and Sanket Dhruva. Dr. Dhruva is a cardiologist at the San Francisco VA and assistant professor of medicine at the University of California, San Francisco. His research and quality improvement work has the goal of improving clinical outcomes among veterans treated with cardiovascular implantable electronic devices through both increasing adherence to remote monitoring and improving the safety of those devices implanted in veterans. Dr. Gabriela Schmajuk is a chief rheumatology is a chief in rheumatology at the San Francisco VA Healthcare System and an associate professor in the Division of Rheumatology, Department of Medicine at the University of California in San Francisco. Her research focuses on improving quality of care and patient safety, with a particular focus on reducing the disparities associated with sex, race, ethnicity, socioeconomic status, and health literacy in patients with rheumatic diseases. Dr. Tonya Kaltenbach is a professor of medicine at the University of California, San Francisco, and director of advanced endoscopy at the San Francisco VA. Dr. Kaltenbach's research is focused on improving the quality of colon cancer screenings through the endoscopic imaging, advanced endoscopic therapies, novel training methods, and the development of evidence-based clinical practice guidelines. Dr. Mary Whooley is a primary care physician, implementation scientist, professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco, director of the UCSF Clinical Research Informatics Postdoctoral Fellowship, and director of the VA Measurement Science Quality Enhancement Research Initiative, QUERI. Her work utilizes data science, implementation science, and health services research methods to accelerate the adoption of evidence-based practices in the VA's National Learning Healthcare System. To start off our session, we want to learn a little bit of our audience, and we'll do two quick poll questions. The first poll question is, what is the role in research and or quality, what is your role in research and or quality improvement projects? A, investigator, PI, COI. B, statistician, data manager, analyst, or programmer. C, project coordinator. D, other. And please describe that via the chat function.
Thank you, Amanda. That poll is now open, and our answers are coming in. I'll just let that run for a few more seconds before we close it out. All right, it seems like everything has slowed down quite a bit, so I'm going to go ahead and try to close out the poll. Sorry, it disappeared from me for a minute. 1 second. All right, we'll close out that poll and share the results. We had 22% said A, investigator, PI, COI, 22% said B, statistician data manager, 8% said C, project coordinator, 5% said D, other, and some of those are operations, VAQS fellow, project manager, implementation scientist. Back to you, Amanda.
Thank you. And our next poll question, how many years of experience do you have working with VA data? A, none, I'm brand new to this. B, 1 year or less. C, more than 1, less than 3. D, at least 3, less than 7. E, at least 7, less than 10. F, 10 years or more.
Great, so that poll is now open. Please remember to hit submit after you've selected your answer choices, or else your answers will not get recorded. All right, it seems like things have slowed down quite a bit, so I'm just going to go ahead and close down the poll and share the results. We have 12% said none, I'm brand new to this. 8% said B, 1 year or less. 13% said more than 1, less than 3. 17% said D, at least 3, less than 7. 5% said E, at least 7, less than 10. And lastly, 6% said F, 10 years or more. Back to you, Amanda.
Great, thank you so much. And now we will get started with the presentation. I will hand things over to Dr. Dhruva.
Thank you so much. Good morning, everyone. On behalf of our project team of Gary Terezovsky, Dr. Mary Whooley, and Dr. Merritt Raitt, I'm delighted to present our work about dashboards to improve remote monitoring adherence to veterans with pacemakers and implantable cardioverter defibrillators, or ICDs, a partnership between the San Francisco VA Measurement Science QUERI and the VA National Cardiac Device Surveillance Program, or NCDSP. As clinical background, pacemakers and implantable cardioverter defibrillators are life-saving, permanently implanted devices. They consist of a generator, as you can see here, generally implanted into the left upper chest, as well as 1 to 3 leads that are permanently affixed into the heart. More than 55,000 living veterans have a pacemaker or implantable cardioverter defibrillator.
Dr. Dhruva, sorry to interrupt. Can you please swap the display? We're on presenter view right now. So
Absolutely. Thank you.
Thank you.
How is that?
Perfect.
Okay, sorry about that. Thanks for correcting. These pacemakers and implantable cardioverter defibrillators, they monitor or initiate every single heartbeat. This means that they generate a lot of very valuable data for clinical interpretation. Remote monitoring or home monitoring is the standard of care for patients with implantable cardioverter defibrillators and pacemakers. You can see here an example of an intracardiac electrogram data coming directly from a patient's heart. The pacemakers and ICDs generate a lot of these data, and these are transmitted using cellular, Wi-Fi, or analog transmission from a patient's residence. These very rich data can help to inform clinical care. For example, they can help us to identify new cardiac arrhythmias or even device failure. For example, the generator battery has died or the lead is failing. Randomized controlled trials, as well as very large observational studies, have showed immense clinical benefits from home monitoring, including reduced mortality, reduced hospitalizations, among patients with defibrillators, reduced rates of shocks, reductions in healthcare costs, as well as improved patient satisfaction and quality of life with remote monitoring. Accordingly, remote monitoring has a Class 1 level of evidence A, that is the strongest professional society recommendation. And recommendations are that these transmissions from pacemakers or ICDs should occur at least every 90 days, or approximately 4 times a year, in order to allow clinicians to review data from the patient's pacemaker or ICD to identify any clinically relevant or clinically actionable events. This is a diagram that shows how remote monitoring works within VA. Here on the upper left, you can see that a veteran is monitored at home and sends scheduled quarterly, again, approximately every 90 days, and also for most patients, alert-initiated transmissions. For example, if a patient has a new significant cardiac arrhythmia or receives a shock from his or her defibrillator, that will be transmitted. Those data are then transmitted to one of the 4 pacemaker ICD manufacturer sites and then reviewed and placed onto the VA NCDSP's secure servers. The VA NCDSP has about 20 reviewers who review about 250,000 remote monitoring transmissions a year. And they review dozens of parameters from these transmissions. I've just put a couple of examples here. For example, right atrial lead pacing impedance or shocks that might have been delivered. If there's an abnormality on the remote transmission, then the NCDSP informs the local VA clinic that manages the veteran, for example, in Houston or Miami, and that local VA clinic then contacts the veteran and takes appropriate clinical action, being informed again by the care and the information that was received from the remote monitoring transmission. VHA Directive 1189, which was issued in January of 2020, requires that all willing and able veterans with pacemakers and ICDs must be offered remote monitoring, and that all remote monitoring must occur through the VA National Cardiac Device Surveillance Program, again, or NCDSP. Now, I want to discuss the need for a dashboard. The approximately 120 local VA clinics who care for veterans, these 55,000 plus veterans with pacemakers and ICDs, they have an information need. They need to know if the patient has missed a remote monitoring transmission or even perhaps never transmitted since being implanted with a pacemaker or ICD. The reason is that without remote transmissions, patients cannot receive those clinical benefits, reduce mortality, reduce hospitalizations, improve quality of life from remote monitoring. The local VA clinics also need to know the interpretation of the remote transmission as well as the details of the patient's device. For example, the model of the generator and the lead or leads that a patient might have. Prior to the implementation of the dashboard, which I'll share with you in the next few slides, this was a very slow and manual process for local VA clinics. Here's a screenshot of a dashboard. I want to first mention that the data on this and the next few slides are all fictional, and that the 120 local VA clinics can only see data for veterans who they are following. So you can see, and we'll walk through the pieces of this dashboard in the next few minutes. You can see in the upper left, here are the active patients that are followed by this test clinic called VA NCDSP. There's a distribution of adherence for veterans that are followed by the specific clinic, veterans who have transmitted between 0 and 99 days ago. And the reason for this is the NCDSP allows approximately a 10-day buffer in addition to the approximately 90-day requirement for transmissions. Veterans who've transmitted 100 to 200 days ago, and there are additional categories not available right now based on the way that this test clinic is set up for veterans who've transmitted 200 or more days or who have never transmitted at all. There's also a couple of bars here that show the overall adherence for veterans enrolled in that local VA clinic's facility. The goal is always, of course, 100% adherence, but at least 80% adherence. So we can see here that this clinic, of the 8 patients, only 5 or about 62.5% have transmitted in the last 100 days. So there's a red bar because they haven't met the 80% goal. However, 100% of veterans have sent a transmission in at least 200 days, meeting the 100% goal over there. On this slide, we can now see a little bit more detail of what's available with the PowerBI dashboard. Here you can see patient-specific information, the patient's name and last 4, the patient's date of birth, the date of the last transmission, and the number of days that have elapsed since that last transmission. The generator type, IPG here stands for implantable pulse generator, and some of the patients have ICDs or implantable cardioverter defibrillators, as well as manufacturer. So this can also be copied onto a spreadsheet and printed out if that might be easier for the local VA clinical care team. We also have information on the patient's devices here, the currently implanted devices. So this is the implantable pulse generator or the pacemaker generator, the manufacturer, the model, and the same for this patient has two leads, the manufacturer and the model, as well as the position of the lead is listed here, as well as the implant date. And here we have the National Cardiac Device Surveillance Program's interpretation of remote transmissions. As I mentioned, the NCDSP reviews all of these transmissions, and here's the clinical interpretation from the NCDSP's expert reviewers for the veterans' 3 transmissions, all of them at high ventricular rate episodes, which were due to oversensing. These encounters actually populate as soon as they occur, as soon as a veteran sends a transmission from their home for 3 of the 4 pacemaker or ICD manufacturers through data connections from the manufacturers to the NCDSP and therefore to the PowerBI dashboard. And the NCDSP is currently working on initiating transfer of data for the 4th manufacturer, thus ensuring that the data are all updated in real time for encounters and then populated thereafter with the NCDSP's interpretation. On this final screenshot of the PowerBI dashboard, for local VA clinics that seek to identify veterans who, for example, have not been adherent for a given period of time, in this case, we've selected veterans who transmitted 100 to 200 days ago. So they've sent at least 1 remote transmission in the past, so they probably know how to and have been able to successfully do so, but they haven't met the guideline of transmitting the last 100 days. So the time period is selected and the list of veterans is immediately made available so that the veteran can be contacted and troubleshooting can occur between the clinical care team and the veteran. There are also multiple search parameters here in the right panel, including the patient's location, the patient's name and last 4, the type of device, manufacturer, transmission category, as well as the dates of the last transmission. This PowerBI dashboard was beta launched to VA clinics on August 12th, followed by a Microsoft Teams demonstration that was recorded and made available. We obtained feedback via a REDCap survey, which was overall positive. There were a couple of requests, including for PDFs of the remote transmissions, which provide additional data that come directly from the manufacturers, as well as some drill down capability, additional details for patients. And we then, at the end of last month, launched nationally to VA cardiology clinics around the country. The next steps for our PowerBI dashboard are to continue evaluation and enhancement. We continue to examine usage, including the total number of viewers, the total number of views. We've reached out with a REDCap survey and continue to obtain positive feedback after this broader launch around the country. We have planned qualitative interviews with both frequent as well as infrequent users to understand what the frequent users are using and what they find to be beneficial, what they might want improved, and with the infrequent users of what we might improve in order to help better improve the dashboard and make it more usable and help to inform their clinical care. We'll also be evaluating rates of adherence for veterans with pacemakers and ICDs with the hope that this additional dashboard will help clinics improve adherence for their veterans. We also have plans for augmentation and enhancement. As I mentioned, we're listening to feedback. As we learned from the REDCap survey, there's interest in PDFs of EKG transmissions. These are actually a large size, and as I mentioned, 250,000 of these are reviewed on an annual basis by the NCDSP, and so figuring out some of the logistics is what we're working on right now. We're also considering adding information about in-person device clinic visits for veterans, adding patient contact information, for example, phone number to make contact easier, as well as drill down capability or multiple views. In summary, remote monitoring adherence is crucial for veterans with pacemakers and implantable cardioverter defibrillators because it improves many important clinical outcomes. Local VA clinics need a real-time mechanism to evaluate adherence, and through a successful operational partnership between the Measurement Science QUERI and the NCDSP, a PowerBI dashboard now solves this important information gap for local VA clinics, and we have continued opportunities and look forward to working to continue evaluating and improving the dashboard. And I'll now pass on to my colleague, Dr. Schmajuk.
Thank you so much. It looks like I will just scroll down here to get to my slides. It's a pleasure to be here today to speak to you about using national Power BI dashboards to improve medication safety in rheumatology. So I'm going to actually start off with a case. So here's a 62-year-old female from China who was diagnosed with rheumatoid arthritis 3 years ago. She was initially treated with methotrexate and a TNF inhibitor, but continued to have active disease. And so her rheumatologist, in collaboration with the patient, decided to change her medication. She was switched from her TNF inhibitor to IV rituximab based on her continued disease activity and her positive lab tests for rheumatoid factor and anti-CCP antibody. She initially did well, but 4 months later was admitted to the hospital with fulminant liver failure. And she was found to have a reactivation of latent hepatitis B with a very high viral load. She died 1 month later while on the liver transplant list. And in the morbidity and mortality conference that followed this event, she was found to have had a positive hepatitis B core antibody that was never followed up on. So here's the problem. Treatment with immunosuppressive medications known as biologics, of which TNF inhibitors and rituximab are examples, can cause fatal reactivation of latent infections such as hepatitis B or tuberculosis. The guidelines that we have from professional societies, including the American College of Rheumatology, recommend pre-treatment screening for hepatitis B, including a surface antigen and core antibody test, hepatitis C, as well as tuberculosis, to identify and treat latent infections. So if an infection is identified, a latent infection is identified, patients can be either treated in the cases of hep C and tuberculosis in advance of starting their medication, or they can receive prophylactic treatment against reactivation in the case of hepatitis B. National data, both from the VA and non-VA settings, suggests that 40 to 80% of biologic users have not received all of the recommended pre-treatment screening tests that we've talked about here. So one potential solution for this problem is to use audit and feedback through an electronic health record-based dashboard to assist with population health management. This would be a single stop that would provide a bird's eye view of medication safety issues for patients in your clinic. The use case would be that the dashboard would be checked by individual providers, practice managers, pharmacists, or trainees, and this could be done on a weekly, monthly, or quarterly basis. Changes made in CPRS or new tests or medications ordered propagate into the dashboard within 24 hours. So although it is not quite real time, it's very close. So here's a diagram that shows how our dashboard was built. So we have local VA, CPRS, where clinicians order medications and also lab tests. This goes into a local data storage, followed by the regional data warehouse and the corporate data warehouse, where nationwide data is kept. We take data from the corporate data warehouse and put it and extract it using a SQL query. It is then uploaded into the Power BI databases, and a dashboard can be generated from there. This short little arrow, which seems very insignificant on the slide, actually takes an enormous amount of work. So we have spent many months identifying the medication users based on tables where both outpatient medications as well as IV medications are located. We needed to identify active prescriptions. We identified and validated all the various screening tests. The names and labels for these screening tests are different at every VA facility. So you can imagine that was quite an undertaking. We collaborated with the liver disease groups nationally as well as some rheumatology work groups, and there were many thousands of charts reviewed by our team. We also needed to identify the ordering providers for the medications so that it would be easier to feedback this information to the relevant parties. So here's a screenshot of the PowerBI dashboard that looks at safe prescribing for DMARDs. This is disease-modifying anti-rheumatic drugs, and on this dashboard we have information about the biologics as well as synthetic targeted small molecules, which have similar risk profile. I'll just make the note that this is fictitious data, and you may recognize some characters from various medical shows on TV. So at the top of the dashboard here, we have some information about the purpose of the dashboard, a key showing that whether or not screenings are completed or designated by a green check mark for yes, a red X for no, and a gray circle for not applicable. We have patient names and their last fours. We also provide the drug class, like a B-cell therapy or anti-TNF, for example, the specific drug name, and you can see that some of these include the biosimilars, which are starting to come out, and then the last prescribed date. On the right, we have columns showing whether hepatitis B screening was complete, hepatitis C screening was complete, TB screening was complete, and all relevant screenings were completed. We also have filters, so you can filter by specific provider, the drug type or drug name, and whether or not all screenings or particular screenings were complete. And I'll make the same note that Sanket made earlier, that only the patients for which you have access will appear on this list. You will only be able to see patients at your particular facility if those are your CPRS permissions. This is one other view that we have available that show expanded patient labs. This is a little bit busier, but for people who need to know which specific tests may be missing, so this is an efficient view for this. So you can see that, like, for this third row here, this patient has a Hep B surface antigen completed, but no Hep B core antibody, and so that's why they have an X. You can see the date of their most recent lab. And finally, there's one other screen that shows the list of providers and which of their patients might be missing, how many of their patients might be missing the screenings required. And we also have some national benchmarking, so you can see how your facility compares to all facilities across the US. We're also building a DMARD safety toolkit. So this is a SharePoint that links directly from the dashboard, where we have video tutorials on using the dashboard, PowerPoint presentations that have background information on latent infections and guidelines and the rationale for this, sample workflows for using the dashboards, and as well as templated communications both to clinicians and patients explaining the goals of screening and how you're remediating any missing screening. So our next steps are to continue to validate the data elements as we roll out the dashboard across more sites. We are continuing to enhance our toolkit. We are planning a pilot rollout to 6 sites who have volunteered to participate. And we're thinking about creating an additional suite of dashboards for other medication safety issues in rheumatology, including those listed here. I'm just going to take one moment to show you one other dashboard that we've already developed, which is looking at hydroxychloroquine. Hydroxychloroquine is a medication that's commonly used in rheumatoid arthritis, lupus, and other inflammatory arthritis. And recent data suggests that retinal toxicity, which we've always been concerned about with this medication, is more common than we thought. The toxicity that we see in the retina is related to the dose and duration of use of hydroxychloroquine. And so there are new guidelines that suggest weight-based dosing for this drug, and that dose should be less than 5 mg per kg per day. We also have data, both from the VA and outside the VA, suggesting that 20 to 40% of hydroxychloroquine users are receiving higher doses than this. We've built a similar dashboard. I'm not going to walk you through it, but it's the same idea as the DMARD safety dashboard, with patient names, last fours, as well as the dose in mg per kg per day for hydroxychloroquine. And what's exciting about this project is that we've actually already launched the pilot study with 6 sites, where we've provided access to the dashboard, as well as monthly learning collaborative meetings with the pilot sites and quarterly site-specific run chart reports. And we're very excited to share that although the pilot sites were actually doing better than the national sites, with only 11% of their patients receiving inappropriately high doses of this drug, they were able to improve very dramatically over the 6-month period where they had access to this dashboard. And so we're excited to see if we can replicate these results using our DMARD safety dashboard. So in summary, audit and feedback using an EHR-based dashboard is one possible solution to the problem of population health management of medication safety issues. And I think another theme that will emerge from our series of presentations is that although data validation can be quite a long process, after the data validation is complete, PowerBI dashboards are fast and easy to build and adapt for additional use cases. I'd like to acknowledge Anna Montgomery, who did many of those 3,000 chart reviews that I mentioned, as well as designing the dashboards, and Gary, who did much of the data work, as well as my other collaborators, and our viral hepatitis and liver disease program and advanced liver disease group, who helped us with many of the data elements. Thank you.
Thank you. My name is Tonya Kaltenbach, and I am going to present on behalf of the QUERI Measurement Science team on colonoscopy quality, as well as the VA Endoscopy Quality Improvement Program in partnership with the GI National Program Office. And we are using PowerBI colonoscopy quality dashboards to reduce colon cancer. So colorectal cancer prevention is a top VA priority, and colorectal cancer is commonly diagnosed in veterans with a 35% 3-year mortality rate. In the VA, there's more than 200,000 colonoscopies performed annually, with about half of them for screening colonoscopy for prevention of colorectal cancer. And colonoscopy is different in that it's not just a blood draw and you have this value that is very reliable. Colonoscopy, in fact, is indeed variable, and it's extremely operator dependent. You can see here, this is just one very small fraction of a colon, and in that you need to have it be cleaned, you need to wash, you need to look behind folds, you need to be able to maneuver your endoscope in order to do those things. The lighting needs to be adjusted. There are many, many variables that impact the performance of a colonoscopy. And when we look at specific markers within a colonoscopy that can give us an indication of quality, the endoscopist adenoma detection rate has been shown to be a strong predictor of colorectal cancer. An adenoma detection rate is the number of patients with at least one adenomatous polyp found during colonoscopy out of all the colonoscopies performed by that endoscopist. And when you look at adenoma detection rate for endoscopists, each 1% increase in their ADR has been associated with a 3% decrease in interval colorectal cancer risk and 5% decrease in colorectal cancer death risk in that endoscopist patient's cohort who they perform colonoscopy in. There was no threshold effect above which increases in adenoma detection rate were without benefit. So this has been shown to be a very strong surrogate marker for quality in colonoscopy. So much so that the U.S. Multi-Site Task Force on Colorectal Cancer has recommended that physicians performing colonoscopy measure quality, including the adenoma detection rate. This is a strong recommendation based on high quality evidence. The VA also has a colorectal cancer directive mandating adenoma detection rates be measured. It's also part of our ongoing professional performance evaluations that adenoma detection rate as well as other colonoscopy quality metrics are included in that evaluation of providers. The problem with all of these mandates and recommendations is it's quite a challenge to measure and report colonoscopy quality metrics. There's no reliable, efficient way of tracking procedure and pathology results to measure colonoscopy quality for the national veteran population. And that's because there's no standardized documentation of colonoscopies, including even note titles of a colonoscopy report. There's no uniformity of an endoscopic report generating application. So there are endoscopic report systems such commercially, and there's no uniformity in those. And none of the current reporting programs actually link to pathology in order to determine adenoma detection rate. So we don't know it's an adenoma officially until it's looked at under the microscope. So the polyp's removed, sent to the pathology lab, and they look at it. And then later on, days later, it's reported back as an adenoma. So there's a big break in time in order to gain this measurement and provide this calculation. And there's no current system to allow us to do that easily. And so there's quite a gap. When we did a needs assessment of the VA quality reporting across the VA, we found it to be quite variable with, in fact, many not reporting any metrics, and then others being variable in the metrics that they were reporting, depending again on the difficulty in obtaining that information to report. So you can see in the middle, the adenoma detection rate, about 60% of sites were able to report adenoma detection rate. And this is largely based on manual review and chart reviews of data. There's no automated system allowing for that metric. And so what we had built as an infrastructure in order to provide quality reporting, including ADR, is finding notes, colonoscopy and pathology notes, through VA national data with the CDW, as well as matching it to demographic information. We then use natural language processing to extract data from the CDW to allow us the indication to identify screening, the bowel preparation quality, extent of examinations in order to provide complete exams, and the adenoma detection. And then we were able to provide quality dashboard reporting to sites and providers with benchmarking. This is produced the VA Endoscopy Quality Improvement Program. This is a program that involves 75 sites across the VA with over 500 providers who perform close to 150,000 colonoscopies annually. And when we look at national metrics for 2019, you can see cecal intubation rates of 91%, the bowel preparation adequacy of 85%, and then the adenoma detection rate of 47%. That means about half of veterans who have a colonoscopy have at least one adenoma found in their procedure. And in looking at the dashboard that we currently are providing to these sites, we are using a SharePoint dashboard. So this is, you can see, this is a colonoscopy quality dashboard for a provider. You can see the provider's names for 2020, and this gives biannual data of their procedure volume and then the metrics, including that ADR with confidence intervals. It's also displayed as a histogram so they can see their performance biannually. And then at the bottom, there are national and local benchmarks provided. So in the blue is the provider's quality metrics. And then in the yellow, that's that provider compared to their peers at their site. And then in the red, it's compared to the national metrics. So you can have that benchmarking. And this is something, the SharePoint data is generated from static data. And this is what is provided through a link to the providers in order for them to see this. And many questions that came back to us when providers looked at this is, can we see the data more granularly? Can we look at our specific patients? Can we see us in relationship specifically to our peers, not just as a bar graph, but like as a plotted graph, et cetera? And we were limited in our responses to provide more dynamic display to them. And so in thinking about improving that, the use of Power BI could improve colonoscopy quality reporting in order to assess colonoscopy volume. And I'll show you where we needed it to apply for that with the era of COVID and colonoscopy volume decreases. Assess the availability of data, so missing data, because we certainly want to capture all when we're reporting quality to providers, and provide the overview of quality as well as that granular level data. And then to integrate national facility and provider benchmarks and really hone down on that dynamic data input so that when we're looking at quality, this is in real time. We want to be able to have it be dynamic and not based on this static input. And so one of the things with COVID is endoscopy came to quite a halt. In fact, screening colonoscopies did, as access to care was more limited. And so when we're providing these dashboards to providers and to sites, we want to make sure that the volume reflects their previous volume. And so you can see here what Power BI allowed us to do is look at the current monthly endoscopy count across many sites and then compare that to the monthly average pre-COVID, looking at these percentages of who has recovered, who is still at a lower volume, and allowing us to target those sites. So it gave us an overview of the volume of at the sites after COVID. This is an example of the dashboard I showed previously, but now using more updated data and allowing us to actually look at sites comparing a station to a substation, for example. And you can see still allowing that national benchmarking, but then within Power BI, we can look more specifically at stations and substations or stations across a VISN. It allows for many more comparisons, as you can see in this slide. And then it also allows us to give an overview, because one of the main intentions of the quality is to identify low performing sites and low performing providers in order for us to do more intensive interventions to improve quality and target improvements in quality at those sites. So you can see here in such a dashboard, we're able to look at ADR performance over sites in that histogram at the bottom. We can get quick feedback into how many VA sites and providers across the country have an under 25% adenoma detection rate. We can give a list of the high performing sites so we can model best practices after them in our collaborative learning and communities of practice. And then we can also identify lower performing sites in order for us to then target those interventions and have closer relationships to intervene and identify areas of improvement. So the Power BI dashboard allowed us a much broader view and overview of sites. But in addition to that, it allows us then to look granularly at each of these rows and then go into the site specifically and into the providers. So it allows this global view, but then it also allows us to go very granular. So in summary, facility and provider use of electronic health record-based colonoscopy quality dashboards may narrow the gap in colonoscopy performance to reduce colorectal cancer incidence and mortality. And the Power BI dashboards are a robust and dynamic colonoscopy quality audit and feedback tool. I want to acknowledge our Query Measurement Science team and the VA Endoscopy Quality Improvement Program team, and specifically thank Grace McKee, a statistician who has been exploring Power BI and ways for us to improve our colonoscopy quality dashboards and provided many of the data slides for us today. Thank you.
And thank you so much. As a reminder for audience members, please put additional questions into the Q&A. And we'll start with some of the questions that were included. Is there any ability to integrate dashboard findings with clinical orders or workflow in CPRS?
Yeah, so I made a brief responses. So unfortunately, Power BI doesn't have a write feature. It would have been really great to be able to kind of dismiss a case or an alert, or somehow put information back into CPRS that the lab was in fact available from an outside source or something, but that's not possible. So in terms of how people are using the dashboard, I think the way that we've had users use the medication dashboard, just as an example, is that they link to the dashboard and they use it to identify the patients that might be missing orders for lab tests or have the an inappropriately high dose of a medication, and so then they will open CPRS kind of side by side and make the changes that they need to make within CPRS, and then the changes that are made in CPRS will propagate through to the dashboard in less than 24 hours. So if they kind of return on the next day, they will see whatever changes they made. We also have the possibility of exporting the information from the dashboard, and so some sites have chosen to have like a trainee work on this as a quality improvement project, and so they download the data into an Excel document, share it securely with one of their fellows, say, who then will go through that list and make changes in CPRS, and then again the changes will propagate through to the dashboard itself.
This is Sanket Dhruva. Sorry to interrupt. I'll just add, I think we have the assumption with the NCSP dashboard that most clinicians have CPRS open at the same point in time, and they might write a note, for example, about contacting a patient or be able to evaluate findings. So we sort of assume that things are open side by side, and that's part of the reason why, as we built the dashboard, we have the first initial of the last name as well as the last four available, so that it's as seamless as possible for what clinicians are used to when they're actually engaged in patient care.
And are there any advantages of Power BI dashboard to the SQL-only dashboards that are often used for VA quality reporting?
This is Gabby. I can speak a little bit to that, because there actually are some medication safety dashboards that exist that have been put together by our pharmacy colleagues that are SQL based, and I think they're extremely useful, and they were very helpful collaborators for us in terms of identifying data elements to use. I think one nice thing about the Power BI dashboards is that you can customize the visuals, so it can be I think like the user interface is very flexible, and so you can change the colors, change the shapes, change the location of things in a more flexible way. And so I kind of see them as complements to one another. I think that the dashboards that exist, at least for medication safety monitoring, that are not using Power BI are very patient focused and provide a lot of information for a single patient, as opposed to showing this kind of bird's eye view of your entire panel. And so I think that they can just be used in different situations. I'm curious how Tonya and Sanket think about it.
Yeah, I would agree, and I tried to demonstrate that the SQL-based dashboards is certainly is useful and such. The Power BI just allows for a more sort of robust display. It's a much more powerful visual, as Gabby said, with comparisons, with sort of the big picture, and then it's dynamic in that you can, like, you go in and it can become much more granular, and so it seems to be a much more powerful way to display the data, and hopefully that more powerful display can be more motivating to providers and how they see it.
Great. Another question. Initially, before getting user feedback, how did you decide what to include in your dashboards? i.e., how did you decide what was worth some dashboard real estate?
Yeah, I mean, I can answer that. We did the number one, what was being required as being measured and reported from national guidelines and VA directives that guided us. And then through a needs assessment, essentially seeing what was not currently being measured and reported, or what was very difficult to be measured and reported. So the combination of those drove our decision to start with 3 metrics, and then we'll expand on it from there.
And how do you disseminate your dashboard links so that users can find them?
This is Tonya again. We currently send emails directly to, for example, a division chief or a site lead for the program, and then the links themselves are the same, but then the permissions are what varies. So there's one link with varied permissions depending on the user.
Great.
And this is Sanket Dhruva, and I'll add the same for the NCDSP. We've shared dashboard links directly with those approximately 120 local VA cardiology clinics, those that have email distribution lists, so that the local VA clinic is essentially responsible for managing that list of patients who helps care for veterans with pacemakers and ICDs. And as they add or remove patients there, they're able to get access to the dashboard through that single link. We do also have some larger sort of parent VA cardiology clinics that have more specialty expertise and that help smaller VA clinics. And so we've also worked to give those sort of larger clinics access to the patients for their sort of smaller clinics that they might help to support, again, through a local national data systems access.
And how does med data get into the dashboard? I am a GI provider with IBD Crohn's patients and have some difficulty identifying biologics.
Yeah, this is a great question. So we started with a list of biologic medications and their biosimilars, as well as targeted synthetic DMARDs that we were interested in as rheumatologists. But it's really trivial to add new medications as they come onto market or become available on our formularies. Or, I think that if we wanted to kind of expand the use case for this dashboard to other specialties, I think we could easily add, the IBD specific medications so that they would be more useful to you as well.
And how accurate or reliable is the NLP data extraction from the reports?
Well, the NLP is not, the NLP, if they're speaking of for the colonoscopy reports and pathology data, has been shown a very high performance with a high F statistic. That's the data we're getting to then, put into Power BI for the display. So the NLP is also the same that's used for, the SQL SharePoint. So it's not as much related to the Power BI as our NLP. It showed a high performance for our colonoscopy metrics, if that's the question.
Great. And what efforts are being made to integrate some of these dashboards or visualization capabilities with Cerner as it continues to be implemented?
Yeah, so so this is Gabby. We're able to see Cerner data in the CDW from Spokane, although we're still in the process of validating that data. But I think that we will have access to data from Cerner sites. So, but I can't speak to exactly how accurate it is at this time. I suspect there'll be a lot of like revalidating.
And a question for Dr. Kaltenbach. Does your provider report enable drill down colonoscopy patient names?
Yes, it does.
And it looks like those are all the questions in our Q&A. Do any of the presenters have any final remarks?
If anybody in this call is interested in using these dashboards, I mean, I would be very happy to share and to get feedback from you. So please reach out to us. My email is on the slides that you're able to download. I look forward to it.
Likewise, I'd add the same, and I think we found that there's the three of us have shared, and all of us working with the Measurement Science QUERI, Dr. Whooley and the team have found that the dashboards are incredibly powerful and have such immense potential to directly inform clinicians. And so consider that there are immense numbers of possibilities, and for those working on quality improvement and outcomes work, immense possibilities for using this tool in your own whether it's colonoscopy quality, medications, or remote monitoring, and so much more.
Yeah, it's really changed the energy of our ability and the potential to display the data. I think that really will move quality more. I think we're all very encouraged and excited by this tool and all its potential to show our data.
Well, thank you so much to our presenters for such wonderful work and a great presentation today. To the audience, if you have any other questions for the presenters, you can contact them directly. Their contact information is included in the slides. Also, please join us October 19th when Dr. Bakor and Dr. Hyde will be presenting Measuring Transformation in Healthcare, Findings and Lessons Learned from the Whole Health Implementation Study. Thank you once again for attending. We'll be posting evaluations shortly. Please take a minute to answer those questions. Let us know if there are any data topics you're interested in, and we'll do our best to include those in the future sessions. Thank you so much to everyone, and have a wonderful day.